Hi. Hello, everybody. Welcome to Knock Knock Hi with the Glockenfleckens. I'm Will Flannery, also known as Dr. Glockenflecken.
I am Kristen Flannery, also known as Lady Glockenflecken.
You keep pointing out my enunciation, so I'm really trying hard to enunciate correctly. I don't feel like I slur my words.
Only when you're doing the fast talking at the end of the episode.
Oh, okay.
When you're doing your regular slow talking, you have plenty of time to enunciate.
That's true. Oh, are you telling me because I talk slow?
Yeah, you're a slow talker.
I know. I feel bad for our listeners sometimes because they have to they should be an option. You think podcasting technology would advance to the point where you can specify how quickly each voice goes?
I like that.
Right?
Because people might want to slow me down or they might want to speed you up.
Well, I think you talk at a normal rate.
I don't know. I've heard in the comments it's a mix.
Really? Some people want you to be faster?
Some people like the fast talking. Some people like this. No, some people want me to be slower.
Oh, really?
And some people want you to be faster.
Everybody wants me to be faster.
Some people are just happy to listen as is.
I grew up in Texas. We talk slow there, okay?
I did too.
Yeah, but you don't really count. I don't know. You had too much
outside influence. Yeah, that's true. Because I'm not a native.
But despite the fact that you grew up in a much more Texas type environment than I did.
Yes.
Like classic
very
Texas.
Rural, small town Texas.
Yeah.
Cowboy
Lots
country.
Of stray animals everywhere.
Oh, yeah.
Stephenville.
Yes,
Remember
near
Stephenville?
there. I sure do. Yes.
That was the big city.
That's where we had to go to buy our groceries.
And that's where the rodeo was?
Yes, they do have a rodeo.
How did you go to the rodeo?
I didn't.
You weren't a rodeo goer?
Not a rodeo person. Could you see me at a rodeo?
Were you in 4-H or something?
No. I'm an inside kid.
I'm surprised your parents didn't.
I am a city kid at heart.
Okay. Yes, you are.
Yes. I like to
I've seen a picture with you with a belt buckle.
Yes. Everyone
and boots.
Mentions that. Do you know why?
Why?
That was meant to be humor.
Oh, I see. You were being ironic.
Yes.
Okay.
It was a senior picture. So it was like, I'm getting out of here. And I thought, it'd be funny.
You're done.
Yeah.
But your parents, did they ever try to make you raise livestock?
No, they never tried to make me do anything.
Like FA?
Yeah, sure. It was very popular. And a lot of kids had a lot of success.
What does it call it? Federal?
Did you just say FAA?
Is it?
That is airplanes.
Oh. Wait, what is it?
FFA, Future Farmers
FFA,
of America.
Not FAA.
Yeah.
FFA.
Look, I don't have anything bad to say about
of course not.
Any of that. It's just that's not who I am as a person. I didn't participate in that stuff. No, I was
I feel like
we're
arguing about who's less or more Texas.
I think that is what we have devolved to. You are more Texas. There's no argument.
I think neither of us are very Texas.
That's true.
So anyway, I don't know.
Maybe
why we don't live there anymore.
Maybe we're an embarrassment to the state of Texas. Yeah.
All right. Well,
then I'm not sure anyone's still listening.
Yes, they are. They love this stuff. Are you kidding me? No, we're talking. We're having a bit of a deep dive into some health policy, healthcare system topics.
Yes.
And which is actually good timing for me because I just had to go through another renewal of my testosterone.
Yeah, explain to people why this is. There's a lot of people that are taking testosterone these days.
It's such a mess.
That is not the situation for you.
My God.
It's not like you're just getting a little boost.
Oh yeah, because I'm getting swole. I'm bulking up.
Yeah, can't you tell? Just by looking at him.
So strong now.
He's tall and lanky.
Actually, I need a new suit because my current suit is getting a little tight.
Mm-hmm.
Not just around the waist, all right? Shoulders. I'm getting bigger.
Yes, you've been doing physical training, and perhaps it's because you finally got the correct dose of your testosterone.
I feel like I have the energy to do it. So, it's
been a learning process. It's 7 years before even we figured out why your insurance company never wants to cover it.
So the reason I don't make any of my own testosterone because I had both testicles removed due to cancer. And so I have to have replacement testosterone but
not just a little extra, all of it, which is exceedingly rare.
It's very rare and also very difficult. I've learned from talking to all my doctors over the years to titrate up to that amount as a young man.
Right.
So I obviously I should have a higher level than someone who's like 60, right? And so it's been a challenge to convince the insurance company that I have to authorize an adequate dose for me.
Which blows my mind because it's also documented that you have no testicles. So
that is the funny part in all of this.
It seems like this should be very obvious
that I have to.
That you need this.
Like I got an approval to have my testapel, so I have little pellets that get shot up into my ass. Not into my ass cheek, I should say.
Yeah, it's a very important distinction. It is not a suppository.
It's a testosterone suppository. I wonder if that exists. Anyway, into my cheek, and it happens every 3 months, and it's
like
I think
Swiss cheese back there.
What the hell are you talking about? I find it very funny that every year and a half, I go through this process with the insurance company where they're like, does he really still need it? Like, I didn't grow more testicles.
Right.
That doesn't happen. I'm an ophthalmologist. Even I know that doesn't happen. And so it's a process we got to go through. And we just recently did it again. So it delayed my testosterone.
Makes me
by
so mad.
A few weeks. And I was feeling real bad there for a while.
Because that's another thing I didn't realize. When you make no testosterone of your own, you get sick. Like, it's not just...
I feel bad. I feel tired and cranky, and I don't know. So it sucks. A lot of people have to go through that, but my situation is just a tiny bit unique because it just doesn't happen very often. But, we eventually work through it.
Again, though, once you've explained it once, it should be obvious that, yes, you need this forever.
But this leads into our discussion today with our guest. So we are talking to Warris Bokhari, MD. He's a former practicing physician, ex-insurance executive. He talks about that, why he started working there, some of the nefarious practices unbeknownst to him. And then why he stopped working there and now is running a company called Claimable that's trying to fight health insurance denials. We also talked to Julie Baak, who is the chief patient advocate and practice manager of the Arthritis Center in St. Louis. So we had an interesting conversation. We talked about denials, appeals, and where
all the insurance company shenanigans.
Lots of insurance company stuff. And so if you're not a fan of insurance companies, this is probably the episode for you.
Yes.
So let's get to it. All right, here is Warris Bokhari and Julie Baak. Today's episode is brought to you by DAX Copilot from Microsoft. To learn about how DAX Copilot can help you reduce burnout and restore the joy of practicing medicine, visit aka.ms/knock-knock-hi. That's aka.ms/knock-knock-hi. All right, we are here with Dr. Warris Bokhari and Julie Baak. Thank you so much for joining us.
Thanks for having us.
Delighted.
I was just reading about the recent lawsuit that Express Scripts or Signa has filed against the federal government, and just really enjoying myself. I don't know if you've been keeping up with what's going on in the pharmacy benefit manager world, but
well, I have not. So why don't you tell us?
Okay, well, why don't you guys? I mean, what do you think about what's been going on there?
I mean, in case you hadn't noticed, I am Jimothy.
Yeah. So we got Warris here. He's wearing a red puffy vest. Yes, just like Jimothy does.
With a slightly handicraft Patagonia logo.
That's
it's like marker.
I never
We're in it to win it.
I never even noticed that at first. So you drew your own.
You
Patagonia
did it so well
logo.
that we were convinced.
I didn't even notice. That's true. That's very well done. I'm impressed by that.
Credit goes to my wife, who wanted to make sure that Jimothy looked authentic enough. But yeah, look, I mean, the Signa lawsuit is hilarious and tragic because it's a complete Streisand effect. So they don't want anybody to talk factually about their business model. So they put out a lawsuit that everybody can then share on social media, which actually that effectively what they're saying is like, exactly. Dear federal government, please stop saying mean things about us, which also, AKA, happen to be the truth.
Right. So what happened back in, I think it was over the summer, maybe a few months ago, the FTC put out a report. Basically, it was wild. It basically blamed the pharmacy benefit manager, the big three, which are like Express Scripts, Optum,
Caremark.
What's the other one? Caremark, yeah. So which are respectively Signa, United, and CVS. And so Aetna, CVS, yeah. And so they put out this report, and Express Scripts, CVS, was so upset that they said, "Oh, this is defamation by the federal government against us, because we are not to blame for rising drug costs." Like they were just very upset by this.
And that this wasn't satire.
No, this is true. This has really happened. And so they decided to sue the federal government for defamation.
This is an Onion headline. Like, this is ridiculous.
Exactly, right? And what I've my understanding is that it's almost impossible to successfully sue the federal government. So I don't know how this is going to turn out for.
Well, what
are
the grounds? Like, if it was just telling the truth about their business model, then
yeah,
the grounds are boo-hoo, and we call CVS and Express Scripts and OptumRx the trifecta of hell. If you want to go ahead and jot that down for some new merchandise.
Well, what I'm excited about is that it's really all this stuff is creating more transparency for the general public about what a PBM is, because there's such a mysterious thing, this middleman of healthcare, that is causing so much destruction in our healthcare system.
Yeah, I mean, they obscure the relationship between a doctor and their patient, right? Because they interlope into that relationship and say, no, you can't have this medication, you can have another medication, which, PS, our specialty pharmacy, also us, will, has in formulary. And,
right.
We may or may not have a relationship with the manufacturer. PS, it's us. And we've literally seen this happen where patients on, Humira are forced onto Imaros by CVS, which CVS manufactures. And, you can argue one way or another about switching patients onto biosimilars or not, which are, effectively generic biologics. That's fine. But when you look at the vertical integration that's at play here, and the fact that all of this is just getting around the Affordable Care Act 15% cap on profits, because they can effectively accrete as much revenue as they want through the PBM and pharmacy channel, which they can't do, they can't do through the insurance side. Right. So it makes perfect sense for them to do that. And they've been very effective at it.
Yeah. And it's what I think is a great thing about this lawsuit that they're bringing against the government for just telling the truth. is that typically, like, there's discovery in a lawsuit. Mm-hmm. So they're going to have to do like the one thing that they probably don't want to do, which is just tell people about their business practices. And so, the truth is going to come out about these companies one way or the other.
This makes me wonder if this is the same people that had an internal meeting about your videos and wanted them, quote, taken off the internet.
Oh, yeah. Let me tell you guys.
Do you know how the world works?
Exactly. Yeah, I did a video about Aetna doing a prior authorizations for cataract surgery, requiring prior authorization for cataract surgery. I made a video making fun of them, and I was told by a source who knows somebody, and
we don't know for sure that it was at Aetna.
Well, I mean, pretty
circumstances aligned, yeah.
And that they were, the chief marketing officer was very upset by my video and wanted it taken down from the internet, which is not how the internet works, unfortunately.
Right. And then, if you want to keep your business model a secret, then a lawsuit is not the way to go.
Yeah, exactly.
Julie knows all about this. She gets calls from Aetna.
Well, and I actually have 2 cease and desist letters, so I must be doing something right, because multi-international billion-dollar company Signa is worried about what I'm doing in Bridgeton, Missouri. Give me a break.
So Julie, tell us about your role in healthcare. What do you do? And
So I am the practice manager and the bathroom monitor for the Arthritis Center in Bridgeton, Missouri. Bridgeton, Missouri is a small little underserved population. I take care of poor people. But what I deliver is a concierge level experience. I have 24 people to support one physician. Therefore, they take amazing care of my patients. If we have an acute new rheumatology referral and a physician or someone from the physician's office calls my office, that patient's in my office in 1 to 3 days. It's unheard of in the industry. But we just work 5 days a week and we answer the phone and we do all the stuff you're supposed to do. And we do it just for the E&M codes.
And then Warris, tell us about, so you're no longer practicing physician. When did you give it up?
I gave it up in 2012, thereabouts. It's like a long time ago. I was a resident in anesthesiology ICU in England. We call them junior doctors, but I think they're actually adopting the term resident. But
I've learned the difference, and so there's a difference in terminology. But
yeah, kind of same thing.
And you were there recently, I saw. But yeah, I mean, I was an NHS doc. I got kind of burned out by some of it. I think just being in an environment where I didn't have like a lot of support for like some of the very, very complicated cases, and like practicing medicine either gets easier for you in critical care or it gets harder because you kind of internalize some of the things you see. And for me, it definitely got harder. And then I ended up meeting this guy called Kerry Mullis, who invented the PCR test. And ended up working with him on an oncology program and a gram-negative sepsis program. And I remember thinking, I lost a lot of patients to gram-negative sepsis, which was really like, it doesn't matter how quick I was on any given day in ICU. I couldn't be, faster than meningococcal meningitis. Like it just was an unwinnable war. So like doing something at scale made sense. Then I ended up in corporate America, worked in a variety of roles. I was at GE. I was at Apple, and then I went to the dark side and became Jimothy in an insurance company. And I'll take questions on that.
Well, yeah, actually, I mean, because you're coming from a different system entirely, right?
Yeah.
You grew up, you started, your introduction to medicine was in the NHS, which is very different than how our system works in the US. And so did you know what you were getting into whenever you started working for one of the main big insurers?
I don't think I understood it very well. I don't think I understood this idea of like, the patient episode is really just a claim, and claims can have various fates within an insurer. I don't think I had any idea of what that would mean to a patient. And I had no idea like how many of these claims get denied or pushed back to the provider for like clarification. I'd never heard of prior authorization before. And my only real exposure to it had been reading Elizabeth Rosenthal's work. And, she wrote extensively on the pains inflicted on Americans, either through unaffordable healthcare and then latterly through denials. And I got really fascinated at wanting to unpick that problem. So even when I was on the insurance side, I was working on programs to give Medicaid patients access to better care and using digital health to like really do that. And we were successful. Like we actually kept a lot of Medicaid patients out of hospital, not through denial, but like getting ahead of their symptoms in asthma. And that was good. But when I realized that insurance didn't really care about scaling these solutions and the work I was being put on was just super not inspiring. Right. I wanted to get back closer to patient care.
Right. And so was there, I guess, how long were you working there? How long were you in that environment?
About 2.5 years.
Yeah.
And, when I started it, no one knew what remote patient monitoring was or digital health. And they're like, build a team. So I brought in all of these amazing people that I worked with at Apple. I brought in, great humans who understood health economics and health policy. And we took a real kind of patient-centric approach. Like, okay, how do we build a program, in Stamford, Connecticut for, Black Medicaid members to ensure that they get to appointments? Or, how do we focus on, removing copays for specialty meds, et cetera, and what are good solutions for women's health if we expand what's considered women's health from just beyond fertility, which is like an overly narrow definition, into all of the other aspects. So like that was kind of a thesis of a team of being really Socratic and like taking like a scientific approach to solving problems. And then COVID hit, and then it just became like an unbridled like disaster of like trying to like, keep patients out of the ER that didn't need to be in the ER. And I remember just dialing for dollars for about 6 months of like everyone I knew, putting together like a coalition to get masks to hospitals and whatever else. And then suddenly everyone became a digital health expert within the company. And none of these people had any idea about patient care. And at that point, I was like, no mas. Like, none of these solutions are going to help people.
I see. So that was my next question is how, because it sounds like you were being set up in this company to do some actual good work, right? To help people. And so there must have been a tipping point, right? Something that just, tipped the scales toward the opposite of that. And you realize that this is not a place for you to be able to do what you want.
I mean, the horizon was very short to like really do real patient centric things, because insurance companies are governed by the quarter. And so maybe you've got 2 or 3 quarters to like show results. But like, if you think about a diabetic patient, you want to show like an improvement in outcomes, that's going to take you,
more than a quarter.
Yeah, it's going to take you more than a quarter, because what's the life of a red blood cell, right? So how do you prove it? And then they would never do studies that big. Like, no one's going to fund that. So it gets hard. And then, some of the women's health studies were just kind of not fit for purpose. And I kind of hit a point where there wasn't a lot of intellectual truth in the work we were doing. And it just wasn't worth my time, because I didn't think it was really going to help patients.
And you also realized they were just kidding.
Yeah, of course. Like there was that kind of unseriousness to it. And I think the last thing I saw was the appeals, like the grievance and appeals process. And I was like, oh, this is a catastrophic mess. Someone should do something about this.
And so you left and decided to really dive into the patient advocate, health advocate type of work. And tell me about that. You both of you went recently to a health advocate summit, right? That was in Las Vegas. I would love to hear about that, being on the light side as opposed to the dark side, and some of the pushback you might have received from the dark side.
CVS got all butthurt and filed a complaint against us. We both were called separately by the organizers of the summit to get our side of the story.
Well, tell us about this. Like, what is the summit? What was the summit?
So the summit's like a 3-day thing in Las Vegas, which convenes like people trying to solve healthcare problems for patients, right? So it's a lot of people like Julie and Julie's colleagues in other states who are all, trying to keep these independent practices alive and get care to patients.
Right. And I was actually asked to speak with my colleague, Nilsa Cruz, who does what I do in Wisconsin. And the title of our talk was Social Media is the New Prior Authorization, right? And like, we're writing stuff like, come here, these two spill the tea, which is completely out of the box for what, most of the time it's like these big, long, boring things. And so wars came down too. And, we are just constantly getting in trouble. Constantly.
Yeah, more.
I don't know what to say. I mean, CVS was the sponsor of this, and they're the frickin' problem. Okay.
Yeah. How does that happen?
I mean, it's kind of like an arsonist sponsoring like a firefighters convention. It doesn't make sense, right? Like and we were told that this particular team at CVS were really brilliant in solving, patient problems and provider problems. So like, we were just really curious. And now I happen to be wandering around with my Sony camera, videoing people and talking to people. And so I wanted to talk to CVS and just get an honest perspective of like, how is it that you guys are like the heroes here, but like you're also the reason why this summit exists, because people have to unpick the madness you unleash on the healthcare system. They got very unhappy.
I bet they did.
Yeah. And
were you wearing your vest too while you were doing this?
I should have done
it. You know what? That was a mistake.
Yeah, next year. Should I get invited? I don't get invited back to a lot of places.
I don't think you're going to get invited back there.
No, probably not.
No, people were running around going, whoever's following Julie Baak around is filming people. And we're like, everyone's on film all the time. What are you guys talking about? Like, and then also CVS had this stupid booth and they had, I don't know, 6 or 8 people there. And then they all sort of, it was like a flock of geese. They were going around him to keep him away from us. And we were charming and lovely. We weren't, actually
like 0% rude at all.
No. And I can be I can be rude, right. Very rude. But I was not in that moment.
We were just at another conference where we got into trouble.
We were in Nashville. Every place we go, we have a problem. What were we doing? We were at the CSRO, the Coalition of State Rheumatology Organization. There was another problem involving you and a camera. Somebody asked him if he was the venue photographer, despite the fact that he has a name tag that says Warris Bokhari, MD. And I'm like, yeah, he's the venue photographer.
I might be. I could moonlight. I'm reasonably good. People are often in focus. Not always.
What did we get into trouble
it was there? you and the guy.
Well,
never received any death threats, have you? Hopefully
just
not.
Cease and desist letters. But I have to tell you, cease and desist letters make for great tweets. And I also have incorporated them into my slideshow.
There you go. It's good content. Yeah.
It is. I'd probably do the same great content. Yeah. I'm surprised you haven't gotten one.
Satire is useful.
Yeah, I get a little bit more leeway because it's a lot of comedy.
Protected by law.
Does this protect me?
I have some. Yeah, I think so. You're wearing that. It's clearly a parody of Patagonia, and so while you can say anything you want while wearing that. Yes, absolutely. I can't protect you from the hordes on social media, but the insurance company, sure, you're fine.
Beautiful.
Let's take a short break. We'll be right back. All right, we are back with Warris Bokhari and Julie Baak. And so I want to dive into how you really started to do the work on like denials and prior authorizations. Do you have a couple examples or an example of maybe a difficult denial that you had to deal with or work through, and that really encapsulates the problem that you're trying to solve here?
I'm happy to start. So I spent a lot of time wondering if this problem really existed, right? So Elizabeth Rosenthal wrote this brilliant article in the Washington Post about denials getting stranger and weirder. And then I dug into some of her KFF data and I was like, wait, 17% of claims are denied, which means that there's, 850 million denials out there. And there's only about 1 to 2 million appeals ever filed in a single year. So if you think about it, and you think 800, they're not 850 million insured Americans, they're like 300 million. So if you do the math and you think that the average person sees a doctor 3 times a year, how many people are really getting affected? And the number I came up with was about 80 and 90 million Americans are getting denied. And then there's so few appeals. So what happens to these people? So I got curious and started looking on Twitter. And I found Julie taking a flamethrower to the insurer. So I called up the practice. I'm like, I'm a doctor. Please don't hang up on me. And she's like, I don't hang up on physicians, and you need to come here and see what's really going on. So the following week, I think I showed up at the office, and we started working on patient cases. So I don't know, maybe you want to talk about some of the things we've seen.
Listen, I had to chuckle when he said, I just wanted to get closer to the patient care. So where does he go? Frickin' Twitter. So at this point in the program, I'd like to thank Signa again, because had I not terminated my contract and trashed them on Twitter, all 900 of my followers, I wouldn't have met Warris. So yeah, so he calls me up and he's like, hey, what are you doing over there? And I'm like, listen, I'm the bathroom monitor in Bridgeton, Missouri. I'm dealing with about 50 denials a week, and I work every one of them myself. I mean, obviously, I have a huge team of people, but anything that they can't get approved comes to my desk. Sometimes it would take me 100 hours to get one patient approved, but I am here for it. I have a skill set that you can't win with someone who never gives up. That would be me. And in rheumatology, there's a giant target on our back because of the price of the drugs we prescribe.
Right.
And it doesn't matter if it's infusion, oral meds, or sub-Q. When these patients are on the right medicine, we do not do a non-medical switch. We were talking about that earlier. We made 2 non-medical switches in 2020, and both of the patients had such severe reactions that they were transported to the emergency room. And I filed 2 med watches with the FDA because those became my prior authorizations for any other non-medical switches. I don't care what company it is. That's just how it is.
Right. And part of the problem, just for context, is that PBMs will change their formularies based on how much money, they call them rebates, how much money they can get kicked back to them by the pharmaceutical companies. And so they'll change what's covered on their formulary based on that, which causes havoc for physicians and for patients, because all of a sudden a medication a patient has been on for years and stable and healthy, all of a sudden insurance won't cover that. And it covers an alternative that maybe doesn't work as well or doesn't work at all for that patient. And so you're stuck between a rock and a hard place of, okay, well, do you make the patient pay out of pocket or do you roll the dice and switch them onto a medication that might not work?
Right.
I heard a case at the conference we were at last week where the doc was telling me that the patient got switched off originator biologic onto like a biosimilar / generic biologic, if you will. And the patient was getting pulmonary issues from their rheumatoid disease. And the insurance company was like, we'll only switch them back if you can provide documentation that they've been in a medical emergency, AKA a invoice for a ground ambulance, transporting them to the emergency room. Like, they're not even following their own policies in these cases.
Right.
So, and that's nowhere in their protocol. Like, there's nowhere in their criteria that's required. Like, we find them making it up on the fly. I've seen cases where insurers will change, like, on the fly, the degree of step therapy they're requiring a patient to go on. Let us say, like, you need to have tried and failed this drug, this drug, this drug. And then I say, just kidding, and this one, just kidding, and this one. And
really?
Yeah.
Right there.
Yeah. They just make it up.
Okay.
And they expect people to just go away. I mean, we had a case with I guess we can kind of talk about it. It's already out there, I guess. But we had a case with Express Scripts where, the patient has cancer, is on the only medication that is FDA indicated to be to be given in that situation. It meets their criteria, and they denied the patient. And then on the back of it, someone there used a fake name to call up the patient assistance line at the pharma company and fill out an application for foundation assistance.
With my information. And fax it to my office for clinician's signature so the patient could go on free drug, despite the fact that she had been stable on this drug for 2 years. Listen, here's the deal. Formularies should be called pay-to-play lists, okay? Pharma pays, and that's how it is. People get confused about formularies, but there's nothing more than the pay-to-play list. Second of all, it can change quarterly, okay? So you add in 9 biosimilars of Humira. I mean, this is like a shell game. So we draw the line in the sand, and we don't do any non-medical switches. And I will fight them tooth and nail. But we kind of get our way a lot.
And then the other problem that exists is that the reimbursement cost for the biosimilars, and this is really the reason that's like driving consolidation, the reimbursement cost is below the acquisition cost. So then these provider groups who are infusing these drugs are losing money, and then they go out of business or they get bought by a large hospital system, which then means the care becomes unaffordable, right? So we had a patient where, it went from clinic care to hospital care. The copay went from $50 to $1,600. And then they had an infusion reaction from the care being given at the hospitals. It was either the wrong drug was given.
They're running an oncology protocol instead of rheumatology
they're running the wrong protocol.
She was sick for 2 weeks.
Yeah.
How is any of this legal?
Well, they have good lobbyists.
And they're writing the rules. They're in charge of themselves. I mean, Optum is like so heavily embedded in CMS and HHS. They get to be in charge of everything.
Yeah, it's in your video. They get to write the laws.
Right. They get to write when you're powerful enough. You get to write the laws. Well, tell us about Get Claimable. Tell us about this and what you're doing to try to fight this.
I mean, everybody's got obsessed with building AI to protect big companies and big health systems. I wanted to do something which was kind of like the ticket clinic, but for appeals. So, you as a patient can now have, the latest clinical evidence brought to bear, clinical studies. We even have like libraries of precedent where the insurer has been beaten on cases just like yours that we can cite back at them. And we use the patient's words. So the AI takes the patient's words and crafts it into a very compelling story. And then it sends the appeal by fax and by mail to the insurance company, to state governors, attorney generals, CMS in some cases, Xavier Becerra, HHS, Lena Khan, if appropriate, like whoever. We've got a big Rolodex of who all of these people are. It's taken a lot of time of like finding humans on the internet, but it's been rewarding. Right. And you can do all of that for like $39.95. So the idea being that we wanted to create like a utility feeling AI and have no interest in collecting success fees, which is, I've seen a lot of actors in this business who are like, hey, we're going to take 20% of your upside. Well, if it's a $100,000 drug and someone's earning $30,000 a year, how does that work? That patient is never going to have the money. So we've gotten patients back probably in our very early scale, like more than $3 million of healthcare value back to them, which has been great. Like they've been, not to overstate it, but lives that we've saved, and certainly like very, very, very delayed care that we've managed to get people, back on schedule.
He built an AI Julie Baak. And
that's right, yeah,
that's what he did, because I fight every one of them. And he did an appeals clinic and brought in like, amazing people. I was fangirling over Wendell Potter. Wendell Potter was in my car. I don't pick up people from the airport, but I picked up Wendell Potter.
Well, so a lot of people are, in a lot of cases, rightly skeptical of AI because there's a lot of people using AI, sometimes for good purposes and sometimes for nefarious purposes, and so what would you say to people that are skeptical of either the accuracy or just the effectiveness of using AI for something as this is obviously really, these are tense situations. Patients are looking at not being able to get their treatment that they need or paying massive amounts of money. So what do you say to them who are maybe like, oh, another AI thing? I mean,
I think it's reasonable to be skeptical. The proof is in the numbers. Like we're beating 80% of these appeals, these denials, right, with appeals, right? So that, I think, happy to, continue to share numbers as things evolve and be
pretty good success rate. How long have you been, have you had this program going so far?
4 or 5 months.
Well, but he's launching his company this week. So like we've just been working together. I don't know. He's been to St. Louis, 3 times?
Mm-hmm.
Yeah.
So yeah, but I mean, it works. And what is the best thing about it is it's not, because it combines the patient story in their own words. You take a $19 an hour employee who has this beautiful written story, but it also looks, she's like 100 lawyers that wrote it for her with overturned case study and law. And all of a sudden it's like hot potato. Does it go to legal? Does it go to customer service? Does it go to escalations? Get this off my desk and approve this. Call that crazy Julie Baak and get this overturned. That's what happens.
So the patients they submit their story, I guess, to you through the website or the app or whatever. And then the AI is using not only that, but also the regulations in place around this medication, policy that's out there, like public policy, to create this appeal package, right?
And it's done in real time. So, it's 20 minutes of airtime of Q&A, asking them very specific questions about their health, which a patient like reasonably knows. I mean, I think that we infantilize patients far too often. And and as a result, we haven't developed good tools for patients, right? We haven't developed things which are truly usable, that feel empathetic, that feel like an experience that they can tell their story to, and like helps them unpick some of that fine detail. Like sometimes you'll ask patients like, do you have any, like, how does this affect your family? And they'll say, oh, it doesn't. And like, what about your grandkids? They're like, well, actually, I can't play with my grandkids at all because I can't get down on the floor. Like, how does this affect you getting to work? Oh, it doesn't. What about driving? Oh, I can't turn my neck when I drive. And that's, caused a couple of, you know what it's like when you're trying to like unpick a medical history. It's the indirect questions sometimes that are very revealing. So we've really thought about experience in that way to like be able to like extract relevant detail from the patient's story. And then the accuracy, we've been super careful. So the reason why we're not open to all conditions and all medications is just the amount of testing that has to go into like making sure that these appeals are actually filed in good faith and are accurate. It's non-trivial to even get to here where it's 20 minutes plus 45 seconds to generate the appeal, and then boom, it's gone. That's been a monumental amount of work.
Sure. Wow.
What are you covering? What would be the right word? What treatments
what's the scope of this program?
So far, rheumatology, gastro for UC and Crohn's, migraine. We met some migraine patients who became like functionally disabled because they're having so many migraine episodes that they could no longer work. And so you start thinking about that, and then you look at the number of migraine patients and all of these new drugs, and you're like, wow, this is an enormous
I see a lot of migraine patients. Yeah.
I'm sure.
I send most of them to a much more knowledgeable neurologist, but definitely can understand the difficulty of getting a hold of some of those medications.
Yeah, and then MS is soon to be added because there are a lot of MS patients who get moved around. It's not a big community, but it's a well coordinated, well informed community who's willing to stand up for their rights. I've started working on cases in oncology, which are hugely difficult. So I've been doing this very manually right now, but we had a patient with stage 4 melanoma who had been denied care for checkpoint inhibitor induced rheumatoid arthritis, which like I'd never heard of. So I had to go back to like, reading PubMed and whatever. And I had to write to the guy at the NCCN and say like, tell me about this. And then he wrote me back and sent me a bunch of literature that I then read, wrote an appeal. Patient had been delayed from further chemo for 9 months. We got it overturned in 1 day because they folded up like a lawn chair. Yeah. They knew this isn't that we're brilliant. I just want to make this really clear. Like there is nothing that we're doing that is brilliant. It's that these denials are capricious, and when confronted with reality, they know it.
Right.
Yeah. So they're really banking on people just not knowing these things are happening and not doing anything about it, and feeling like, well, I got a bill, I got to pay it.
And we know that based on the percentage of denials that are appealed, which is abysmal.
Yeah.
Right. So. Well, and the thing is, for me as a physician's office, like I'm just an unimportant independent contractor. No one gives a rat's behind from the insurance company if we write letters of medical necessity. It's just constantly, we didn't get it. Well, yeah, you did. But now the patient has a contractual relationship with the insurance company. That's a thing. And the patient sends in an appeal, stuff starts happening because now it's serious.
It's awesome when it goes to the governor and then the governor opens an investigation. I've seen that a couple of times.
Yeah.
Which is that's kind of great.
We had the Department of Pharmacy open up an investigation into one of the trifecta of hell PBMs, and they've been in my office multiple times. I'm like, receipts, it's my specialty. Here you go. And that was on the Humira switch to one of the PBM owned and manufactured thing, and it completely blew up. Yeah. We haven't heard any problems with Humira getting denied anymore.
No. I guess this is an important distinction that I think kind of just dawned on me. So these are appeals coming from the patient's perspective,
correct?
Versus the medical practice, which you already mentioned how many appeals you process, every day. And so it carries more weight for the insurer to hear from their customer.
Their member,
whatever they want to call them, right?
Right.
And by the way, that patient's appeal is being sent to these very powerful organizations and people.
Yep.
And so that's why you're getting the attention of the insurer. Okay.
You know what I would like? Going back a ways, I guess, but Humans of New York, or there's, accounts like Good News Movement that are just sort of like aggregator. Well, they're not entirely aggregator, but, they just like curate a bunch of stories and just publish that, right? Like different things that are happening, right? I want an account like that that's just sharing stories of these denials of like, this is what they did, right? This is what they were supposed to do, and then this is what they did, and just making that public.
That's in my plan. Like ultimately, I care very deeply about telling like human-centric stories, and it's like why I'm continually roaming around with a camera. Because to capture the patient stories, like it matters. And like when I was at medical school, the thing that, as a budding photographer, and it was like almost a career at one point, but like it occurred to me that the medical textbooks, like you'd see rheumatoid hands and the eyes were blacked out. Right. So you're literally learning medicine, but you're stripping the humanity away from the patient. You're just learning the signs and symptoms, right? Or it's an eye in your case, but without a face. Right. Sure. So, and therefore you never actually understand like the functional limitation that this brings to a person. You never really understand like the things they can't do. And actually at school, I wanted to do facial plastics, and a lot of it was like oncological reconstruction. I did like quite a lot of research on that in my 20s, and like you would just see that like a lot of these patients with severe facial disfigurement became completely isolated. And that was kind of like part of it as well, as like this exploration. So we've been working with a photojournalist who's a really interesting guy to capture these stories. He actually was a Pulitzer finalist. He was actually in the Capitol on January 6th. And then was briefly on the FBI's Most Wanted until they realized he was press.
I was about to say, he's on the good side of January 6th, right? Fascinating.
But I think we need more of those public, places that they can't control, like social media, making it public what it is they're doing, because they require so much, confusion and silence around it in order to get away with these things.
And there are some news investigative journalism outlets that are doing some of that work, like ProPublica. But it's not enough. And there needs to be something that's a little bit more digestible on a smaller scale.
Right, because even like I am an intelligent,
TikTok,
educated person with an advanced degree, and I'm having trouble following all this, right? Because it's just so
complicated.
It's complicated, and it's obfuscated, and it's intentionally so. So we need things that make it very simple and illuminated.
If only there was like some kind of social media, maybe even like a comedian position, like who could maybe like take some of these things and like just like 90 seconds. I don't know. He could dress up in characters.
Maybe that guy should get to work. I don't know.
We're happy to give you stories. We're happy to give you material. We've got tons of it.
needs to get to work.
Yeah,
he does.
Well, the other part of Warris's of the claimable appeals is the last 2 pages are. And by the way, if you uphold your denial, this is my request for the entire claims file from the past 3 years, which includes recorded calls. So you get that little bomb on your desk, and now you're looking at that costing the insurance company
like $3,000
or more. And they're like, get this approved and out of here. But I think that the important thing here is every one of us is a patient. Every one of us has been delayed or denied care. Yeah. So it's a super relatable thing.
I would put it, I would not, I was thinking about this. Breaking Bad would never have happened if Walter White was just able to appeal for out-of-network coverage for his chemo. He would have had no need to have ever become a meth cook. It would have been a very, very short and very different show.
That's true.
$50, he would have gotten care.
Yeah, he would have been like, okay, I'm done.
Yeah.
So
what about the patients that maybe can't afford the $39.95 per appeal? Are there any plans in place to help those people?
So great question. A couple of things to know. So when we were developing this, we did a bunch of research with a group called Savvy Patient Cooperative, who anyone building a digital health experience, like they will save you years of your life by corralling like actual real professional patients to come talk to you about your business model. They give you the lived experience. And so we did like a lot of price sensitivity testing. And when we showed people, what do you think this costs? The average answer was around $200 to $300. So, and the question was very simply like, at what price would this be a bargain? At what price would this be a ripoff? And the median was around $80 would be like what people would think would be acceptable. So we're pricing under that. But if someone can't afford it, we've had so much interest from pharma and from distributors who are kind of saying like, look, we'll pay. And then we've also got clinics who are saying, we will pay for our patients. Like, you have a character that's rural medicine. There's I met a clinic in Oklahoma who are like, look, we don't want our patients to pay for this. We will pay for this. It's a time saving for us.
Right.
And so
huge time saving. Like that, that's what I was thinking is like, hospitals, clinics, independent clinics who are sometimes just fighting for every cent they can get. Would probably greatly benefit from something like this.
Well, and we've talked to pharma about giving the patients a voucher because they're paying to put these patients on free drug anyway. So you might as well make this a step before you pay for free drug. They have to make a patient appeal, and they're getting overturned like this.
Yeah, because they know they should be doing it. So I mean, that's certainly part of it. But yeah, I mean, affordability is like on my mind. Like, I essentially grew up in a Medicaid family. I had 2 disabled parents. So like thinking about what that means to people. Right. But if it means that the patient gets access to a medication that's hundreds of thousands of dollars, then, they might well do it. A manual case we did was a liver transplant.
100 hours of his time.
Like, it took me 100 hours to write that appeal. I'm not sure we can really automate that, but the guy got a liver. He's at home.
It capitulated in 5 days.
Yeah. They just rolled. I mean, and they were using criteria from 2002, just FYI, which is when I started medical school.
Right. Well, I'm glad to hear that you're really, you have that in your mind in terms of affordability and trying to make this accessible to people.
What can people do? Is there a place on your website where they can contact you if they need that financial assistance? Or
there's a support. There's a support.
Great.
But in theory, it will either they will be referred by the practice, or they can do it themselves. So we'll look at it on a case by case basis. But we think the price is pretty reasonable given. Given given the research we did and kind of the acceptability overall.
Well, and the other thing is that I'm really good at my job, but he's better. The first 3 cases I gave him were cases that I couldn't get overturned. And I thought, let's just go, baby. Let's do this. And most of them capitulate in 5 to 10 business days. But he and I worked on a case that overturned in 2 hours. These people are so sick of me. So sick of me. I'm sure it's like an email from Julie Baak.
Yeah.
So I want patients and practices to have a Julie Baak because he's better than I am at this.
Well, by the time this episode goes live, people will be able to go to your website and sign up if you want. It's getclaimable.com. Is that right?
Yeah, that's right.
And anything else you want people to know about this?
We're really in this to help the patients. Like this is really like trying to give the patients a megaphone to allow the people who don't have voices to be heard. And we want ultimately we want the insurers to do better. They may not go anywhere. I mean, I grew up in socialized medicine. That may not be a reality in the United States, and if it was, it might just be Optum.
Yeah.
But we want them to do better. Like, we want them to engage with their members. We want them to listen to the things they build without ever seeing a member, and make it work. Yeah. A lot of these things would, if they followed their own policies, a lot of these things would never happen.
Well, I think it's a fascinating program, and sounds like a great way to try to, fight these denials. And so getclaimable.com, and then Instagram, you have an Instagram account at getclaimable as well. So Warris, Julie, I want to thank you so much for joining us. It's been a pleasure to talk with you.
Thanks for having us.
Sure.
Thanks, guys. Hey, Kristen.
What?
You know what mites do when they get excited?
What?
They dance. They dance. They dance all over your face. You got these on your eyelids. You know that, right?
I do not.
Well, some people do.
Okay.
They're Demodex mites.
Yes.
They cause blepharitis, which is like red, itchy, irritated eyelids, like flakiness. Just want to scratch your eyes, and don't do that, by the way. But yeah, sometimes that's from disease.
Demodex dance.
It's the Demodex dance on the eyelids, except it's not that fun because it gives you all those symptoms. All right. So yeah, but they're cute, right? They're not. Yeah. They're not gross.
These ones are these stuffy versions.
Right. Oh, the real ones, not so much.
Are the real ones gross in the microscope?
They're still. I think they're still cute, but again, I'm an ophthalmologist.
Yeah.
But don't get freaked out by this.
Okay.
Get checked out.
All right.
All right. You go find out more. Go to eyelidcheck.com. Again, that's EYELID check.com to get more information about Demodex and Demodex blepharitis. Well, Kristen, is your head a bit spinning from all of the health policy discussion?
Yes. Why does it all have to be so complicated and confusing? Hopefully, a lot of people listening to this, are familiar with it at least somewhat through their jobs. We do have a large number of healthcare workers listening, but for those of you who are not, I don't know. I hope you hung in there. I think it's important, and I am interested in it.
So this really is.
This is part of the problem.
Yeah. Well,
that if an intelligent person can't understand everything that's happening, like we need to back up a few steps and make it clearer. This is something that affects every single American.
So, I think the most fascinating thing about what they're doing is coming at this from the patient side of things, the appeals process.
Yeah.
I didn't put that together. The fact that we're always so focused on, the medical practice, the physicians, we have to do these, we have to try to get things covered. I do it with my testosterone replacement. It's like, I don't do the appeal.
Right. The doctor does.
The doctor does the appeal because ultimately, they're the ones that need to get paid for a lot of the work they do. Right. I'm just trying not to have to pay too much.
Right.
But so the idea of having the appeal come, basically doing the work for the patient and submitting it, I could see that as having much more weight with the insurer.
Yeah.
And so I think this is the first time I'm really hearing of somebody, because a lot of people are doing work on trying to limit the amount of denials and things, but
that's like a reimbursement perspective.
Yeah, coming at it from the patient side of things, where you do the work for the patient and then it's coming from the patient. Sure, like AI is involved in that, but they're still taking the patient's story, and then
right. I would love though to see that. I think it's a wonderful first step.
The fact that we need it in the first place.
Well, that's right. That is ridiculous. But also, I want me and other regular people to be able to understand what it is that's happening, what work is being done on their behalf.
Yeah,
can AI explain it like I'm 5, right? Like, what is going on with these things? People, if they are end users of this insurance policy, they need to be able to understand the policy. That, I think, is a huge part of the problem, because insurers are relying on the fact that we don't understand our policies and we don't understand our rights and we don't understand the process by which we can make appeals. They're relying on that. And so I think something that first of all draws attention to the fact that all this is happening, and secondly educates patients in a simplified manner about all of this, is also necessary. Not sufficient to solve the problem, but certainly necessary.
Yeah. Yeah.
So somebody get on that. Business idea of the day.
Do it. Do that thing. Do that thing. Well, tell us what you guys thought of the episode. Love to hear your thoughts. Email us, knockknockhi@human-content.com. Visit us on our social media platforms and our Human Content Podcast family. They're on Instagram and TikTok. They're doing lots of cool stuff lately.
Yeah, they got a lot of cool podcasts.
A lot of really good stuff at Human Content Pods. Thanks to all the listeners leaving feedback and reviews. We love those. If you subscribe and comment. By the way, if you want to just comment, you can, but we really do appreciate the subscriptions as well. On your favorite podcasting app or on YouTube, I'll give you a shout out, our YouTube channel, at Glock and Fleckens.
That's right.
That's where we post all these. At Jessica Young 8530 on YouTube said, I look forward every week to your episodes.
Oh, thank you.
We appreciate that. And full video episodes are up every week on that YouTube channel at Glock and Fleckens. We'll also have a Patreon, lots of cool perks, bonus episodes, react to medical shows and movies, hang out with all the people in our wonderful little Knock Knock High community, early ad-free episode access, interactive Q&A, live stream events, much more. Patreon.com/GlockandFlecken or go to GlockandFlecken.com to find more information about lots of stuff. We got lots of stuff on our website, don't we?
We sure do.
New member shout out, Patreon community perk, Scott W., Stephanie M., and Susan F. Thank you all for being patrons.
Welcome. All S's.
Oh, yeah, that's kind of sweet.
Lots of this week.
Lots of S's. Shout out to all the Jonathans as usual. Patrick CC, Sharon S., Edward K., Stephen G., Jonathan F., Marion W., Mr. Granddaddy, Caitlin C., Brianna L., KL, Keith G., JJH, Derek N., Mary H., Suzanne F., Jenny G. A., Muhammad K., Aviga, Parker, Ryan, Muhammad L., David H. ×2, Gabe, Gary M., Eric B., Marlene S., Scott M., Bubbly Salt, and Pink Macho. A virtual head nod to you all. Patreon roulette, shout out to, thanks for doing the head nod. Patreon roulette time, shout out to someone on the emergency medicine tier. We have Sally. Thank you, Sally, for being a patron, and thank you all for listening. We're your hosts, Will and Christopher Flannery, also known as the Glock and Fleckens. Special thanks to our guests today, Warris Bokhari and Julie Baak. Our executive producers are Will Flannery, Christopher Flannery, Eric Cordy, Rob Golden, and Shanti Brick. Editor and engineers, Nathan Portiza. Our music is by Omar Vinci.
My goodness.
To learn about our Knock Knock High's program, disclaimer, ethics, policy, suspicion, verification, license terms, separate release terms, go to glockandflecken.com or reach out to us at knockknockhigh@human-content.com with any questions, concerns, or fun medical puns. I could do like the fast talking at the end of like a pharmaceutical
I don't know
ad.
that you can because you often don't enunciate while you're doing it. You just kind of slur your words.
Knock Knock High is a human content production.
Knock, knock, goodbye.
Hey, Kristen.
Yeah.
What do you think about clinical documentation?
Boo.
You feel that strongly about it?
I do.
Why?
Because your doctor ends up spending all their time typing little notes on their little computer instead of like listening to you or looking at you in the eyeballs.
Well, it sounds like your doctors could use DAX Copilot.
I bet they could.
Yeah, this is like a little Jonathan in your pocket.
Yeah.
It's an AI assistant that helps decrease the administrative burden that leads to burnout and leads to like your doctors not being able to look at you while they're talking to you.
Yeah, it helps them do their little typing and take their little notes without having to do it themselves.
93% of patients say their physician is more personable and conversational with DAX Copilot. You love conversation.
I do, and I want them to be a person.
And that we need that because today's physicians are overwhelmed and burdened and they feel like work-life balance is unattainable.
That's right.
And we know that work-life balance makes you a better physician.
That's right.
To learn about how DAX Copilot can help you reduce burnout and restore the joy of practicing medicine, visit aka.ms/knockknockhigh. Again, that's aka.ms/knockknockhigh. Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.